Welcome to the deep dive. Ever found yourself wondering, how your neighbor seems to thrive on cigars and coffee, zero heart issues, but then a friend, super careful with their statins, ends up needing bypass surgery? It feels like a total lipid lottery, right?
It really does. That kind of observation, it really makes you step back and question what's actually going on. And it perfectly sets the stage for the complex topic we're digging into today.
Absolutely. So this deep dive, it's all about trying to navigate the incredibly complicated and often contradictory world of statins and heart health, because what our source material points out is that neither side in this, great statin debate is giving you the whole picture. Mm-hmm. Our goal is to help you get balanced, clear information.
Exactly. And the source we're exploring today is a really insightful piece called To Statin or Not to Statin, What Neither Side is Telling You. It's by Dr. Lutz E. Kraushar. He's got a Doctor of Public Health and MSc in Exercise and Nutrition, and he runs the Substack newsletter, Double Check Doc. So he brings a really interesting multi-layered view.
Yeah, and that's what we want for you today. We're definitely not here saying take this or don't take that. Nope. Mm-hmm. We want to equip you, give you the tools to have a better, more informed chat with your doctor, and maybe just as important, with yourself. Dr. Kraushar uses this great analogy. He calls it biology poker. Mm-hmm. It's a game, he says, of incomplete info, chance, and skill. And we're here to help you pick up some of that skill.
And what's really striking right from the get-go is how both camps, the pro-statin folks, like the European Society of Cardiology, the ESC, and the critics, right, they often point to the exact same big clinical trials. Jupiter, prove it, improve it, AFCAPS, TEXCAPS.
It's wild, isn't it?
Yeah. To back up completely opposite arguments, it's like they're witnesses for both the prosecution and the defense using the same evidence.
It really is a paradox, looking at the same numbers and seeing, different things. So let's lay out the ESC's general position. They basically stand on three pillars. One, LDL cholesterol, that's the bad cholesterol, is the major cause of atherosclerotic cardiovascular disease, ASCVD. Two, they see the link between LDL and ASCVD as linear, meaning lower is always better, no bottom limit, really. And three, they argue lowering LDL will cut your ASCVD risk no matter where you started.
Right, that's the foundation for a lot of the guidelines we see. But then you've got the critics, and they essentially say, hold on a second. They question that direct link, saying it's not so clear-cut. They also raise concerns that many of the key studies might be biased. And maybe most importantly, they point out this gap between the actual biology of how plaques form and just getting a good lipid score.
So you have this strong stance and then this significant pushback. But, and this is really crucial, there's actually common ground. Both sides do agree on this. Inflammation and something called endothelial cell dysfunction, or ECD, are absolutely necessary triggers for ASCVD. They're key to how it starts and progresses.
Yeah, that's a point of consensus.
Despite all the other disagreements, they land on that biological truth.
And that shared piece about inflammation and the endothelium, it naturally leads to the next question. How does a plaque actually form? Because it's definitely not just like your kitchen pipes getting clogged. That's way too simple.
Right, that's a huge oversimplification. Think of your blood vessels lined with this incredibly thin layer, the endothelium. It's meant to be a tight seal, but trouble starts when the junctions between these cells get damaged or leaky.
Exactly.
That's when these larger LDL particles, the ones carrying cholesterol, can kind of sneak through into the space just beneath that lining, the subendothelial space. And that's where the problems begin.
And this is where that endothelial cell dysfunction, ECD, really comes into play. Healthy endothelial cells, they actively fight against plaque buildup. They reduce inflammation. They prevent clots. They love smooth, steady blood flow, what scientists call shear stress.
Okay.
But if the flow gets rough, turbulent, or just too weak for too long, maybe from not moving around enough, a sedentary lifestyle, those endothelial cells get stressed, they don't function right, and the junctions become leaky.
So LDL gets trapped behind this leaky barrier and then it gets oxidized. Our immune system sees this oxidized LDL as like an invader. It sends in these cells called monocytes.
The cleanup crew.
Yeah, the cleanup crew. But they can get a bit overenthusiastic. They just gorge on this oxidized LDL until they turn into these dysfunctional things called foam cells. Those are the early signs, the fatty streaks.
And it becomes a vicious cycle. The foam cells die, spill out their toxic stuff, which ramps up inflammation even more, and eventually you get these fibrous caps forming, and calcium deposits, that's the stuff you see on a CAC scan, a calcium score.
Okay, so understanding that process, it sheds light on why there are different views on LDL's role. The prostatin side often talks about transcytosis. The idea here is that endothelial cells can actively, pull LDL particles from the bloodstream and pass them through to the other side into the artery wall.
And if that's the case, and it scales with how much LDL is in the blood,
then lowering LDL becomes a really obvious strategy for almost everyone. It strengthens the case for broad statin use.
But then there's this alternative idea, the inside Job theory. This suggests that maybe, just maybe, plaques can start forming even behind a healthy, intact endothelium. The cholesterol might come from smooth muscle cells deeper in the artery wall, especially if the process of getting cholesterol out of the wall does HDL's job, reverse cholesterol transport, isn't working well.
Which shifts the focus a bit, right? Not just LDL, but maybe HDL function is just as critical.
Exactly. But, regardless of which theory holds more water, or if it's a mix, both sides still circle back to inflammation and endothelial dysfunction being the essential starting point for trouble.
Which brings us back to a really fundamental point, something cardiologist Dr. Rita Redberg famously said. Cholesterol is just a lab number. Who cares about lowering cholesterol unless it actually translates into a benefit to patients?
That's the bottom line, isn't it? The goal isn't the number itself, it's helping the patient, preventing actual events.
So let's look at how the prostatin side translates this into action, usually through guidelines. In Europe, the ESC and EAS often use a treat-to-target approach. They use the SCORE risk calculator. It looks at your age, blood pressure, LDL, gender, even your country.
Right.
And Dr. Kresshar gives this example. A 55-year-old German guy, non-smoker. Based on the calculator, it's almost impossible for him not to get a statin recommendation unless his LDL is incredibly low already. He'll likely fall into a risk category where they aim for a 50% LDL drop.
And it's a similar story in the U.S., though maybe slightly different phrasing. The AACC guidelines use more of a risk-based intensity approach. They might recommend a statin aiming for, say, a 50% or greater LDL reduction depending on your overall risk.
And remember that big shift in 2013, the U.S. guideline revision. Overnight, it essentially medicalized almost 13 million adults who were previously considered healthy. Think about that suddenly. Potentially 1 in 2 healthy adults in the U.S. qualified for statin consideration.
That's huge. And it brings us to something really, really important to understand. The difference between proportional and absolute risk reduction. The guidelines often show these graphs, right? Like reducing your LDL by 1 millimole might give you about a 20% proportional risk reduction. Sounds pretty good.
Yeah, 20% sounds significant.
But here's the crucial part. What does that mean for you personally? Let's say your actual absolute risk of having a heart attack over the next 10 years is 5%. A 20% proportional reduction on that 5% risk means your absolute risk drops by only 1%.
From 5% down to 4%?
Exactly. Now, it's still a reduction, but it sounds a lot less dramatic than 20%, doesn't it? Understanding this difference is like a key card in your biology poker hand.
Absolutely critical. And it leads right into what Dr. Kresshar calls the 90-100 question. If being high risk means maybe 10 out of 100 people like you might have an event in 10 years, what about the other 90?
Right. What else is going on?
What other factors decide who's in the 10 and who's in the 90? It clearly suggests there's more to the story than just LDL.
And this is where the skeptics really make their case. Now, Dr. Kresshar calls himself a skeptic, but he's careful to clarify he's not anti-statin. He sees their value. His issue is more with, as he puts it, lording them over millions of people who wouldn't need them.
Yeah, the broad application.
And interestingly, he actually critiques some of the skeptics' own arguments too, finding what he calls sloppiness on both sides.
So he dives into the specific arguments, some skeptic claims like about flawed meta-analyses or the ecological fallacy, which is basically saying you can't apply group averages perfectly to individuals. He finds they have some weaknesses, or the prostatin side has counter-evidence. But he highlights 2 areas where the skeptical view seems pretty strong.
Okay, what are those?
The first big one is what he terms the 2004-05 watershed. This was a major legal change after scandals like Vioxx. Pharma companies then had to register clinical trials before starting them and publish all the results, good or bad.
Transparency rules.
Exactly. And Kresshar found that a really influential meta-analysis from 2010, one the ESC relies on heavily, included 26 trials, but get this, 21 of them were done before this 2004-05 rule change.
Wow, okay.
And even some of the studies done after the watershed weren't properly registered beforehand or at all, like one called ACEPIN, which actually showed no significant benefit from the statin. He also points out that none of the ESC's key meta-analyses were registered in Prospero, which is kind of the standard for meta-analyses since 2011.
So Potential issues with the older data's completeness or reporting.
Potential issues, yeah. And then there's the second point, which Dr. Kroshar calls the oh boy moment, conflicts of interest. He looked at the authors of that key ESC position paper. Yeah. A whopping 24 out of the 26 authors reported getting significant money from pharma companies or sitting on their boards. He jokes, as far as I can see, there is no pharma company that is not listed here. He adds a funny line about believing in Santa Claus and the Tooth Fairy, too.
Implying a certain level of, shall we say, necessary skepticism about objectivity when there's that much industry involvement.
Exactly. So where does that leave us? Well, there's definitely reason for caution, looking at potential bias and maybe issues with older data. But it's also clear LDL is involved in ASCVD, and lowering it does help some people avoid bad outcomes. The kicker is neither side can really tell you, the individual, with certainty, if the drug will benefit you.
Which brings us right back to that element of chance in biology poker. Two researchers, Arbabzadeh and Fuster, they describe a heart attack as this kind of accidental perfect storm.
Perfect storm, I like that.
Yeah, it requires 4 things to happen all at once. 1, you need existing plaques. 2, one of those plaques has to rupture. 3, a blood clot has to form, and it needs to be big enough to block flow. And 4, your body's natural clot-busting system has to fail to clear it quickly enough.
Only if all 4 line up.
Only then do you get the actual heart attack. And the role of chance here is bigger than you might think. Check this out. Something like 80% of adults under 50 already have some atherosclerosis starting.
80%.
Yeah. And maybe 1 in 3 people actually have plaque ruptures and clots forming fairly regularly. But the yearly rate of actual heart attacks or acute coronary events in people over 40 is tiny, like 0.2% to 1%. Millions of people have these ruptures happen every year and don't even know it.
That's mind-blowing. So where does cholesterol fit into that storm?
Well, it's mainly involved in condition number 1, the buildup of the plaque itself. So lowering LDL, the idea is it reduces the probability of that first domino falling, makes the storm less likely. But it doesn't really fix the underlying issue, the cracks in the endothelium caused by inflammation.
It doesn't repair the dam, it just lowers the water level a bit.
That's a great way to put it. And only really restoring that endothelial function can fix the dam. This leads it to the number needed to treat, the NNT. This is like your odds card in the poker game. It's simple. 1 divided by the absolute risk reduction.
Okay, let's use our example again. Risk goes from 5% to 4%. That's a 1% absolute risk reduction.
Right. So 1 divided by 1%, or 0.01, gives you an NNT of 100.
Meaning
you'd need to treat 100 people with that exact risk profile for the specified time just to prevent 1 single heart attack. The other 99 wouldn't see that specific benefit, though they might get other effects or side effects.
100 people to prevent 1 event. That really contrasts with the 20% reduction headline, doesn't it? Your personal odds are 1 in 100.
It puts it in perspective. And Dr. Kroshar looked at the NNTs from those 26 studies. For patients who were already in the hospital for a heart attack or similar event secondary prevention, the NNTs were much lower. The drugs clearly helped more people in that high-risk group.
Makes sense.
But for studies published after that 2004-05 watershed, especially looking at primary prevention, treating healthy people to prevent a first event, the NNT shot up to around 250.
Oh.
Yeah. Which, as Dr. Kroshar notes, kind of feeds that suspicion that maybe some bias did inflate the benefits seen in the older studies. It really highlights how the potential benefit changes dramatically based on your starting risk.
Okay, so this is a lot to take in. How do you actually use this information? How do you play your hand?
Dr. Kroshar proposes a pretty straightforward 3-step strategy. This is designed to help you have that informed conversation with your doctor. Step 1. Take a look at the official guidelines, the U.S. decision tree, or the ESC recommendations. Understand the standard approach.
Step 2. He actually provides a downloadable scorecard on his site. Now, it's not an official risk calculator. He's very clear about that disclaimer, but it's designed to help you gather your personal factors and get a better feel for your specific risk situation.
And step 3. Look at those number needed to treat figures we talked about. Try to understand what the potential benefit looks like in absolute terms for someone like you.
Right. There are just too many individual variations to cover every possibility here, but going through these steps can really help you personalize it, get a handle on your own situation before you talk to your doctor.
Exactly. The aim isn't to have all the answers, but to have a solid foundation for a meaningful discussion.
Okay, now, for our wrap-up, the one more thing.
Oh, yeah.
While making lifestyle changes might not slash your LDL numbers quite as dramatically as a powerful statin can, those changes can massively reduce your actual risk of heart attack, stroke, and all the bad stuff that comes with ASCVD.
And here's the kicker.
Often on par with statins, and sometimes even more effectively.
This is such a critical point. For example, every little bit helps with fitness. Each 1 MET increase in your cardiorespiratory fitness, that's a measure of aerobic fitness, can cut your risk of dying from any cause by about 11% and dying from cardiovascular disease by 15%. That's significant. And diet. Switching to something like a Mediterranean-style diet has been shown to reduce cardiovascular risk with an NNT around 75. Remember the statin NNTs we discussed. 75 is definitely in the same ballpark, potentially even better than the NNT for primary prevention with statins in some groups.
So why is lifestyle so powerful? What's the mechanism?
A huge part of it, especially with exercise, is its direct positive effect on endothelial cell function. It helps restore and protect that crucial lining. That's something statins just don't do directly. They lower the LDL, but lifestyle can actually help heal the vessel wall.
You can even track this, right?
Yeah, you can monitor things like endothelial function using measures like pulse wave velocity or PWV. And Dr. Kraushar himself is kind of a walking example of this. He shares his own lipid numbers. Total cholesterol 151, LDL 57, HDL 71. These are, well, they're incredibly low.
Off the charts low, almost.
So low that standard risk calculators often won't even accept them. And he takes no statins, no heart meds at all.
And how does he do it?
Purely lifestyle, he says. He exercises 5 times a week, eats loads of fruits, very few processed foods. And interestingly, he mentions eating meat daily, so not strictly Mediterranean, but clearly whatever he's doing is working incredibly well for him.
It's a fantastic illustration of how a personalized lifestyle approach can have profound effects, maybe even beyond just tweaking a single number like LDL.
Absolutely. It underscores that potential.
So wrapping this all up, the whole statin question, it's way more nuanced than the headlines often suggest, isn't it? It's this complex mix of biology, statistics, that element of chance we talked about, and yeah, a need to critically look at sources and potential biases.
Definitely not a simple yes or no answer for everyone.
Which leads us to our final thought for you to chew on. Given how central endothelial function and inflammation seem to be, and seeing the documented power of lifestyle to actually restore function, what parts of your daily habits might be your smartest bet in this game of biology poker? Think about Dr. Kraushar's example, his non-standard but effective diet plus consistent exercise challenges, some common assumptions. Maybe the key really lies in finding those personalized approaches that go beyond just the LDL number for long-term heart health.